Okay, this is a brief presentation on genetics or inherited things and epilepsy. So seizures or epilepsy. Epilepsy is defined as more than one seizure. So if you have a single seizure, it's a seizure. But if you have more than one, it's actually defined as epilepsy. Both infantile and childhood, as well as adult onset epilepsy, can have many causes, including metabolic disorders, brain malformations, infections, and single gene causes. So basically anything that can damage the brain can increase the risk of epilepsy. One of the most common single gene causes of epilepsy is an abnormality in electrolyte channels in the neurons. Epilepsy occurs in about 1 to 2% of the population. 70% of childhood epilepsy has an inherited cause. Genetic testing should be considered in any child with epilepsy. So in childhood epilepsy, approximately 24% have a chromosomal microdeletion. And we're going to discuss more about chromosomes and microdeletions next year, but there's actually a problem with their chromosome material. And sometimes the seizures occur so early you don't even recognize that they have cognitive delays. So 24% of children that have a seizure, especially during early childhood or infancy, have a chromosomal abnormality. 40% have a single gene problem. So bottom line, about 70% of children who have epilepsy have some type of genetic cause. Some is a chromosomal deletion or duplication, and the majority is a single gene mutation. Adult epilepsy, while there are single gene causes of adult onset epilepsy, the incidence is much lower in adults and children. Additional causes of seizures in adults includes trauma, which they have more time in their life to have trauma, alcohol abuse, brain tumors, stroke. Inherited epilepsy cause of seizures should be considered if there's a family history of non-traumatic seizures. So with pediatrics, we usually just go right to genetic testing. With adults, there usually has to be something else going on. So let's talk about inherited epilepsy, a single gene or Mendelian disorder when the mutation or single gene is responsible for the seizures. So when as far as genetic causes, a chromosomal abnormality probably sometimes, but in most cases was de novo, not inherited from a parent, whereas inherited genes can be. There can be also variability of the severity of the seizures among family members. So just in general, the risk of epilepsy in the general population is 1 in 100, which is a pretty big number. There are a number of genes associated with inherited non-syndromic seizures. And what I mean by non-syndromic seizures is when a child has a disorder that causes severe brain malformations and other kinds of, other syndrome, then the risk of seizures is, dependent on that small group. Many of the genes associated with ion channels involve neurons. Again, these ion channels, the child doesn't have extra fingers or toes or look dysmorphic in any way, they just have seizures. Uncontrolled epilepsy, however, can lower IQ in children. So intractable epilepsy, so if you have a normal brain when you're born, 50% of the brain grows in the first 2 years of life. So it's growing in size and it continues to add neurons and other kinds of things. Adults that begin having seizures as adults do not lose IQ. However, in children, IQ is significantly lost. It's estimated that they lose 8 points per seizure because the brain is growing and developing and myelinating. And so epilepsy during childhood affects cognition. And that's going to get back to some of our inherited genes. If a parent had a gene that caused seizures and had 1 or 2 seizures during childhood because they didn't have a severe time with it, and they grow up, they pass that gene on to their child who has severe epilepsy status during critical points of brain development. That child can have severe cognitive deficits more because of the seizures than because of the gene. And so here's adults, when adults have seizures, they don't lose intelligence. Single gene disorders associated with seizures include tuberous sclerosis, Rett syndrome, Fragile X, and leukodystrophies. We are not going to be discussing these disorders, so I'm just saying single gene syndromic. So I talked about non-syndromic. There are a lot of syndromes that are very much associated with seizures, but we're not going to talk about that today. Single gene causes of non-syndromic, like I said, they look normal, there's nothing else wrong with them. The first that's really important is the GLUT1 glucose transport, and GLUT1 is also known as SLC2A1. It affects glucose transport into the neurons. When the neurons don't have sugar, they get really pissed off, and when they get pissed off, they seize. So even though there's glucose in the blood, the neurons cannot transport it into the neurons. Seizures usually begin during infancy. So here we have the GLUT1 receptor, and the glucose is transported from the outer membrane to the inner membrane, but when this receptor is not working right, the glucose, even though it's on the outside, can't get to the inside. Lack of glucose, as I said, makes the neurons very unhappy and they seize, and this gene is inherited in autosomal dominant fashion. And most of the time, it's a new mutation. Only one copy of the gene needs to be non-functional to have symptoms. But the treatment is actually a ketogenic diet. So we talked about ketogenic, like ketosis and fatty acid oxidation disorders, which is the worst thing you'd ever want to put a patient with a fatty acid oxidation disorder on. But what happens in the ketogenic diet is we switch the form of energy, so we can't get glucose in to make the neurons happy. So let's get ketone bodies in there to make them happy. And the sooner we start this, the less the child seizes, the more cognitive function we can rescue from this child. So a ketogenic diet is a diet high in fat and proteins. I know a lot of people have tried the ketogenic diet and limiting carbohydrates. So no bread, no pasta, no sugar, no milk, no corn, lots of meat, green vegetables, not a little bit of avocado, and some berries. So not so many berries, lots of meat. And again, this makes the liver think the body is starving. And so when the liver thinks the body is starving because it doesn't have sugar, it starts breaking down fats and making ketones. And then the ketones can cross the blood-brain barrier and make the brain happy. And this is the sooner we start this, the better off we are. Another common, well, not, inherited non-syndromic seizure disorder is Dravet syndrome or myoclonic epilepsy of infancy. Seizures begin in the first year of life. They're often associated or precipitated with having a seizure, a fever. So they're like, oh, it's a febrile seizure, which we don't worry about the first time, but when it keeps happening again and again, we have to start getting concerned. 85% of patients with Dravet syndrome have a mutation of the SCN1A gene. And the SCN1A gene is important in sodium transport with the action potential across the neurons. It's inherited also in an autosomal dominant fashion. And seizures can progress to tonic-clonic or even absence seizures. Seizure frequency decreases or ceases during adulthood. However, poorly controlled recurrent seizures in infancy and childhood can result in cognitive delays. So it's possible, this is a dominant, that the parent maybe never had a fever or really precipitated this, maybe had one seizure when they were an infant and didn't really go on to full-fledged epilepsy, and yet they pass on this non-functional SCN1A gene to their offspring, and they have a bad fever and they have a lot of seizures, and then those seizures cause more brain damage and things get worse and worse and worse, and now they have very severe cognitive deficits. So one thing I really want to emphasize is these gene changes increase the risk for seizures, but seizures alone increase the risk for cognitive delays. So as I said, SCN1A is inherited and autosomal dominant. Most cases are de novo or a new mutation. However, again, one family member could have it, but not have a severe symptom. So here we have somebody that's had benign epilepsy, means they've had seizures, it's not a big deal, and passes this on actually to both children, probably, because this individual never had a seizure but had a child with a seizure. This individual had a child with mild seizures, no seizures, and then very severe manifestation known as Dravet syndrome, because that individual, even though they all have the same gene, had a more severe, maybe they had a bad fever at a bad time and downhill. So if a parent has idiopathic epilepsy, idiopathic is one of my favorite words in all of medicine. Idiopathic means I'm an idiot because I have no idea what causes this. So a parent has epilepsy. Nobody knows why. The risk of having a child with epilepsy is about 9 to 12%. Some are inherited, most are not. So when we look at a big population, the empiric risk is 9 to 12%. Genetic testing is recommended in all children and infants who develop epilepsy. And the reason is some of these genes, there's specific treatments for the SCN1A. We put patients with GLUT1 on a ketogenic diet. So, choosing the right thing to do. There are some other rare forms that respond to vitamins and things like that. So any infant, we want to see if there's an inherited cause because it may help management. In some cases, like I said, with the GLUT1, the ketogenic diet will help. Controlling the seizures in infancy and childhood is the most important thing to prevent the cognitive deficits. So here's a USMLE-like question, and I took this out of a book, so I apologize if it's not the best written question, but anyway, a 2-year-old female presents in status epilepticus. Her first seizure was at 4 months. It was associated with a febrile illness. Her second seizure was at 9 months. The second seizure was not associated with a fever. Now we have two seizures that constitutes epilepsy. Since that time, she's had 2 to 3 seizures a week. The EEG shows generalized spike wave pattern. Her gross motor and cognitive development is delayed. She smiled at 2 weeks. She sat up at 6 months, but lost that skill after the second seizure. She's now having difficulty with PO feeding and recently had a G tube and Nissan placed for reflux. She does not pull to a stand, and she has no verbal speech. The family history indicates the mother had a febrile seizure as a child. She had no additional seizures. A clinical diagnosis of Dravet syndrome is considered, which gene is associated with this. And so we went through this, but SCN1A, we haven't gone through the rest of these genes. The first one, UEB3A, is associated with Angelman syndrome, which we'll talk about next year. SLC2A, the GLUT1, but that's a glucose transport, and MECP2 is another inherited disorder associated with Rett syndrome. Again, we will review these next year, and this is not a question I would ask you on the exam. It's just a question I took out of the book, but it tells you that the patient has Dravet syndrome, and so this is actually an important. So these two genes, I want you to know these two genes, just because they're common, and like I said, if they asked a board question, you need to know that gene. So that concludes this small